Hey everyone, I hope you're doing well. My name is Dr. Shahid. I am a medical doctor from Pakistan, and I will be applying for the upcoming residency maths cycle in internal medicine. And I just wanted to make this video for aspiring interns and young medical students that are, getting in their rotations or they're finishing their rotations or they're in joining their internships, whether it be in Pakistan or anywhere else in the world or in the United States. So this video is basically on the SOAP notes or the SOAP format of taking medical histories. So as you all know, taking medical histories is an integral part of the patient care setup. Without a history, you have no idea what's going to happen, what's going on with the patient. So it's an extremely crucial aspect of patient management and care. So without further ado, I'm just going to get right to it. So what is SOAP format? So it's basically the way of taking an entire patient, presenting an entire patient history. So the SOAP is a mnemonic. It stands for different subsets of the patient case presentation that you're going to do. So the S in SOAP stands for subjective. So this is basically all the stuff that, you know, that the patient basically tells you, or something that you cannot, quantitatively assess in the patient. So this is something that the patient would tell you on the history basically. So this is the history portion of the SOAP format. So in this one, you're just going to ask the patient all the questions about their illness and what brought them into the hospital, get a detailed information about you know what their symptoms were and blah blah blah. So the way I like to go about doing this is when I start with subjective, there's another mnemonic that I use. It's called PAM hits FOSS. So initially, we're going to go with the history of presenting illness. So first of all, before the HOPI, we go with the presenting complaint. So what did the patient come in with first? So for example, and you should go with this in a chronological order. So basically what the patient had before, that should be in the beginning. So, for example, a patient had like a headache for the past month. So that's what their initial symptom was. So you start with the headache 1 month ago. Then they started developing nausea 2 weeks ago. Then they had vomiting a week ago. So that's how you're going to start. You're going to start with the headache first. Then you're going to mention the nausea, which happened 2 weeks later. Then you go with the vomiting, which happened 1 week later. And now their main presenting complaint, which was loss of consciousness and seizures. Okay, so and that happened like a day before their admission. So that's the chronology of the presenting complaint. You get done with that, good. Now you go into the HOPI. So now you ask them the details of their complaint. And there's a mnemonic for this as well. So the one that's most commonly used is OFDPA. So what does that stand for? O is for onset. So you ask them the onset of the condition. Was it sudden? When did it happen? Was the onset gradual? Was it sudden? Was there? So that would be the onset. Then you go with the F. What does the F stand for? Frequency. So whatever his symptom is, how frequently does it happen? Was it a one-time thing? Is it happening recurrently, or is it happening constantly? So for a good example for this could be pain. Pain could occur, over certain periods of time, frequency dependent wise, or it could happen, as a constant thing. Someone's constantly in pain, they're not getting any relief. It's just there all the time. So that's how you would define the frequency. D in OFDPA is the duration. So how long has this been going on for? Is this something that started a few days ago, a few months ago, whatever that may be? And then in the duration, you can also ask them if they've had any prior episodes. So, did this happen to them before, or is this a first time occurrence? All right, so that's an important thing to know. Then the A in OFDPA basically associated symptoms. So, has the patient had any other symptoms along with the presenting complaint? Do they have any nausea, vomiting, fever, joint pains, arthralgias, anything you can think of? Basically, you just ask them, like, do you have any other symptoms apart from this? If they're not able to remember, then you can go ahead and ask them all these close-ended questions like, have you had any fevers, any vomiting? Like if you, for example, you had a patient with chest pain that's substernal, the most important thing you think of is, is the patient having any symptoms, associated symptoms of, a heart attack? So, you might ask them about palpitations, you might ask them about diaphoresis, you might ask them about any nausea, any vomiting, you might ask them about any loss of consciousness, anything like that. So that would be the associated symptoms. And apart from that, you're gonna, so that would be the OFDPA. And then the other thing is P Lycra. Well, that's for pain. Basically, the P is for pain if they have any pain. Then when you ask about pain, there's a whole other mnemonic. It's called, you can go with it, the Socrates, which is basically site, onset, character, radiation, aggravating or alleviating factors, exacerbate, associate symptoms, um, and what is the timing of the pain and the severity. So Socrates is a very good mnemonic for that. So basically, you just ask them everything about their HOPI. Try to get as much information as you possibly can. Dive in. Don't waste. This is the one portion of the history where if you spend a good amount of time, you will get a very good, picture of what the patient is going through. So this is the most important aspect, I believe, of the history. So you're done with the HOPI now. Then we come into the mnemonic. So apart from the mnemonic, sorry, before that, when you're done with the HOPI, the next thing you should do is review the systems. So just go through all his systems generally, ask them symptoms relevant to their organ systems. So if you're reviewing a patient with, heart failure, you can review their other system. You can ask them about their urine output, check their kidney function, ask them if they've been urinating, any changes in the urinary habits, any blood in their urine, any difficulty urinating, any blood in their urine, any pain during urination, and then you can ask them questions about their GI tract, any difficulty in swallowing, any nausea, vomiting, any loss of appetite, any change in bowel movements, and you just go into all these different organ systems. So the main ones that we usually go for are the lungs, respiratory system, the cardiac system, the peripheral extremities, the GI, genitourinary systems, the reproductive systems, the psychiatric system, the endocrine system, the musculoskeletal system, the hematologic system, and the nervous system. So these are some of the main organ systems that one should focus on when going for a review of systems. And it's pretty straightforward to go through in these individually. Just think of all the different symptoms that people could have if they had diseases of these organ systems. So, if someone had any disease that you want to check their, previous systems, and you want to do their nervous system, for example, you could ask them about any history of seizures, any history of any tremors, any history of any limb weakness, any difficulties in, maintaining their gait or walking, any history of any loss of consciousness, any dizziness, or any neuropathy, any tingling or numbness in their body, stuff like that. All right. In endocrine, you could ask about diabetes, any symptoms of hyperglycemia, any symptoms of thyroid disease, stuff like that. So recap, we've discussed the HOPI, we've discussed the presenting complaint, we've discussed the review of systems. Then we go on to the mnemonic that I was talking about, PAM, HITS, FOS. So you review the other things. So what is the PAM, HITS, FOS? The P is the past medical history. Any prior medical illnesses that the patient may have. Most patients that come in are going to have chronic illnesses like diabetes, hypertension, coronary artery disease, stuff like that. So it's good to know about all these diseases and what has been done for those diseases so far. So that's past medical history. A is for allergies. It's important to know what allergies the patients have so we can know which medicines not to give them. Then PAM, so M stands for medications. Which medicines are the patients taking, and what is their dosing, what is their frequency, what was the indication for the use of the medicine, and how are they using them? Are they compliant with the use of these medicines? Are they receiving them on time? Are they taking them on time? These are important questions to ask. So then you have PAM, then you have HITS. So H is for hospitalization. Have they ever been hospitalized in the past? If so, what is that hospitalization for? Then I is for any infections they've had in the past, some recent infections or past infections that they had. T is for any history of any travel, in case you're looking for any infectious diseases or diseases that are relevant to travel history. Any occupational diseases or any diseases that occur in different regions in the United States. You could ask them about their travel history. Then S is for the social history. Well, actually not social history. That's actually the S is just random. So you could just go PAM, HIT, FOS. I guess that S is just irrelevant. So let's go the FOS. So F is for family history. So you're gonna ask them about their family history. So their parents, are they alive? Have they passed on? And what diseases do they have or they had? You ask them about their siblings, if they're healthy or not, if they have any diseases, and that runs in the family. It's important. Then you go for O is for OBGYN history. So that's obviously for female patients. You will ask them about their menstrual history, the age of their menarche, when their last menstrual period was, Have they experienced any symptoms of dyspareunia, dysmenorrhea, or excessive vaginal bleeding, excessive menstruation, menorrhagia, or any other symptoms like that? Any vaginal discharge, any bleeding, any pain during coitus, anything like that, and pregnancy history. How many births did they have? How many times they have been pregnant, and if they have had any complications during pregnancy, or have they had any operations on their reproductive organs. So these are important things to ask in the OBGYN history. Then the FOSS, so FOSS, so social and social history and sexual history. So in the social history, you basically go in for the habits the patient has, any alcohol use, any smoking history, any drug use, what does the patient do for a living, and what their living conditions are like, how many beds in their house, how many people live in their house, and access to drinking water that is safe and stuff like that. Then in sexual history, you ask the patient about if they're sexually active or not. If so, how many sexual partners they've had in the past year. Do they practice safe sex? Do they use condoms or any reproductive equipment that allows them to prevent pregnancy? And have they had any prior sexually transmitted diseases? And if so, what have they done for that? Have they received any treatment? So that's the sexual history. So one thing in the PAM that I forgot to mention was the past medical history. You should also ask the past surgical history, if they've had any operations in the past, and what the indication for that was, and what were the outcomes of that, and if they've had any blood transfusions in the past, as that can be very important with reference to infectious disease that are spread via blood transfusions like hepatitis C or B. Okay, so that's the HOPI and the review of systems and the review the entire patient history basically in subjective. So PAM, HITS, FOSS. So it's quite a mouthful to get into, but I think it should be quite helpful when you're dealing with patients. So that's how I go about it. So in review of systems, another mnemonic that I learned was, it's very nice as well. It helps you get a general idea of things. It's called JADE Tab March. So J in JADE stands for jaundice, A for anemia, D for diabetes, E for epilepsy, T is for TB, A is for any asthma, B is for any bronchitis, M is for any MI, A is for any I don't even know what A is for, I forgot. R is for any rheumatic heart disease, C is for cholesterol, so any hyperlipidemia, and H is for hypertension. So these are important things that one can ask in the review of systems, just to get an idea of what's going on with the patient. So that's it for the subjective aspect, I guess, of the history. Now we move on to the objective. So an objective, what do? You will ask about the patients, basically about you're not going to ask them anything, sorry, you're just going to do things. You're going to examine them. So physical examination comes under objective, because it's something that you can assess objectively without some biases in there. I mean, there's some biases in physical examination, but overall physical examination is considered an objective parameter. So physical examination, do the relevant physical examination to the organ system that's affected. If you have time, you can do other organ system assessments as well. Particularly the neurologic system is important, especially in diabetic patients. Apart from that, what else can you look at in the objective is the labs. So the patient's labs, any recent labs that they've had, any imaging studies that have been done, record those and get the relevant ones done, and try to assess what you can get from that. Okay, it's very important to get all the relevant information that's important to the patients presenting complaint. And the other things, an objective are urine output. So measure the urine output. If they've got a Foley in their intake output charting, their vital signs, those are also an important part of the objective parameters. So yeah, that's objective. Then when you're done with these, the next thing you go for is the assessment and plan. So in assessment and plan, basically in assessment, you're gonna basically put down all the important problems that the patient has. So if they have diabetes, you mention diabetes. If they have hypertension, you mention hypertension. If they have epilepsy, you mention epilepsy. If they have like a cough that brought them in, you mention cough. Then you write down a brief assessment that you've made. For example, a patient has a productive cough with mucopurulent sputum, which is being produced which is having a large quantity. So he's got massive mucopurulent sputum. along with fever and tachycardia. All right, chest X-ray showed consolidation in the bilateral lung fields. White cell count showed a white cell count was more than 15,000. His RFTs were deranged, likely AKI. AKI would be a separate problem, but in the setting of this, you could mention it. The next thing would be he's got temperature of so like 100 and 103 degrees Fahrenheit. So you're getting a picture of all these problems he has. So this is your assessment. He's got infiltrates in his lungs. He's got fever. He's got white cell count elevation. He's got a cough. That's mycopurulent. So that's your assessment. So you're thinking, community acquired pneumonia or bronchopneumonia, or complication of bronchiectasis that's happening. So you can mention this in your assessment, and then in the plan you're going to mention what you're going to do. So start empiric antibiotic therapy, coverage for community acquired pneumonia. So you're going to give them antibiotics like fluoroquinolones and macrolides or fluoroquinolones, and you're going to give them either as IV or oral depending on the patient's presentation and how seriously ill they are. You're going to mention that. You're going to mention giving them IV fluids. You're going to mention all these different things that you would do in your plan. So the next thing would be, like I mentioned, if the patient has an AKI, you're going to mention that in your assessment. AKI, reduced urine output. They have their RFTs are deranged. You're going to mention their sodium is this, their creatinine is this, urine output is this, their hemoglobin is this. Then you're going to mention the likely intervention. So stop all nephrotoxic medications, renally dose their medications, give them IV fluids if they're being, give them a fluid challenge, or give them Lasix to check if they have urine output. Monitor their urine output hourly, stuff like that. Give them blood transfusion if their hemoglobin is too low. Consult nephrology. So that's your plan for your assessment. So that would be the entire output or the entire format of the SOAP: subjective, objective, assessment, and plan. This is what you're going to be making up, and this is how you're going to be presenting the case to your attending. You go with all these things, then you lay out a plan, and then you talk about what you're going to do next. So this is what I believe is what SOAP is, and this is how I've been dealing with it. So yeah, if you have any questions or queries, please feel free to comment in the comments below, and I hope to give some more information to you guys when I get any new knowledge in this medical field. Thank you very much.